Welcome everyone to this webinar from the ECARIS project. And today we'll focus a bit more about how we deal with challenges when you're a kidney patient. We'll have two presentations today. The first off, Daniel, thank you.
I'm going to say good morning, everyone. Yeah, I'm going to share my screen. I think you can see it now. And yeah, I'm going to now. Okay. My pleasure to be invited to share with all of you the impact of COVID-19 on kidney patients. As you know, we have a tough situation due to the pandemic. So we are trying to do our best because we learn every day, every week about the situation and how to improve the quality of life and care of kidney patients. I'm a kidney patient undergoing hemodialysis at home. I'm a lucky one of the patients that are undergoing the treatments at home. And I'm also the president of the European Kidney Patients Federation since last month. So it's my honor and my pleasure to share with you all the information. Okay. Now, yes, as you know, the kidney population with health conditions across Europe is approximately 75 million of people of population, which is almost the 10% of the population. So we are talking about a huge number of people that have kidney health conditions across Europe. This is very important to have in mind that we have more people with kidney disease that, for instance, unemployed people in Europe. So this 75 million of people, which is an approximate number, only an estimation, we have to tackle the problem about the kidney disease and increase awareness about this disease in the agenda of the policymakers and the European health across Europe. So you can see here more or less the numbers about the registry of the people in the several kidney replacement therapies, which are hemodialysis in red, and also the advanced chronic kidney disease, which is estimated we have 25 million, which are stage 3 and 4, and we have in hemodialysis and peritoneal dialysis only 30,000 people, which is a tiny number of people at home. In transplant, the registry was 240,000 people, which are transplant, but of course the number are more big now because we are in 2020. And in dialysis, I'm trying to move now. You can see the number. We have at least 370,000 people in hemodialysis. And so this is the real picture about our data of the kidney replacement therapy and the worst stages that are stage 3 and 4. And regarding the stage 3 and 4, they have the immune system affected, and despite the 80% have moderated symptoms, they are in risk, and they could be considered a high-risk group, and they have and should stay at home. But we have this fragility in this group because they are with a hypertension or obesity, or they have a diabetics, or they are very fragile and in this group. So our recommendation, of course, is to stay at home and to have telemedicine or to have a phone consultation and try to keep the personal safety regarding the health stay at home. Regarding the kidney transplant group, they are immune compromised. They have a high risk of pneumonia. They have seen the regular revisions postponed, and you know they have to go to the hospital to the consultations and to pick up the medication. We have seen the transplant activity have fallen due to the COVID-19, and they have to wait 21 days for donation in case of they have to do with the COVID-19. And the living donor, they have to wait 3 months at least to have to do the donation regarding the living donors. Of course, our recommendation is to stay at home and to try to control the temperature and all the situations regarding the kidney transplant to keep their health stay at home at least as much as possible. Regarding the peritoneal dialysis and home hemodialysis, of course, we have seen that the home therapies are the best solution to try to control the pandemic and to try to avoid to go to hospital. And of course, they have the telemedicine and phone consultations and in-home assistance to try to see how is their health at home. And the home diet, the material reception and protection, the home supplies are guaranteed at home. We have seen a lot of cases of peritoneal catheter surgery without priority, and not only in peritoneal catheter, but also in the vascular access. So we have seen this delay in the catheter surgery without priority in the peritoneal dialysis, and we are claiming for that because we think that we should promote these home therapies because are the safest treatment during the pandemic. And of course, the worst group are the hemodialysis patients, because they have to undergo 3 times a week, 4 hours every 2 days. We are recommending that the people should go in his own vehicle, on their own vehicle, without caregivers or companions, and because this public sanitary transfer, they are a high risk of infections. We have seen that there is no waiting rooms in the dialysis unit, and the recommendation, of course, is at the general population to use a facial mask during the sessions without no food service. And we have seen separate shifts to try to avoid the infection, because they have separating free and suspect and infected patients. It depends of the situation of each group is managing everything. But of course, they are not. They have no chance to stay safe at home. What are our concerns regarding the COVID-19 as kidney patients? We have focused in the kidney replacement therapy patients because the personal safety are in risk, and the access of medication is not easy, not only in dialysis but also in the kidney transplant. We have seen a delay in the vascular access surgery due to the isolation at home, and we are claiming because we don't have a clear public health guidance. We are claiming for protocols. It is true that we are learn a lot every week, but we would like to have more coordination and more clear public health guidance. And of course, we have to address the emotional disorders regarding the pandemic, not only in general population, but also in the kidney replacement therapy patients. And of course, for the acute or the advanced chronic kidney disease patients, we have seen a pause or delayed diagnosis in the treatments, and it is not easy for the kidney patient to access to the healthcare professionals because the phone are overload, and it is not easy if you call to a hospital or dialysis unit to be to reach some professionals. And of course, we have seen the same and a clear public health guidance, and we have seen a lot of treatment delays, and as a result, we have a worsening health in this group, in the kidney patients. And this brings a paradigm shift. We have seen a lot of changes in the landscape of the quality of care, because hemodialysis patients are not able to remain safely in their homes. So the hospitals and dialysis unit are not the safest place as we used to be. So we are claiming that that the chronicity should be addressed at home, and the home therapies we have to promote that just to avoid to go to the dialysis units and hospital. And the kidney transplant activity, of course, are reduced because we have seen during the pandemic the only emergency transplant has been released, and the COVID-19 patients can become kidney patients. As you can see, the kidney is one of the organs, the most affected organs about the COVID-19 disease. We have seen a disruption in the quality of care because we don't have developed in time the telemedicine and the regular consultations by phone, sorry. And we would like to have access to the medication, and not only in the hospital but also in the pharmacy, in the community, or even the supplies at home. Maybe we can prescribe the medication at home. And of course, we have seen that the people we are recommending to do telework or temporary unemployment at home, but of course this is a crucial problem that we have seen during the pandemic, that not everybody could do telework or to have an employment even at home. And as a patient organization, we have seen a real paradigm shift, because we are trying to continue offering support, but we are struggling and we are fighting with the pandemic, and we are trying to avoid this social exclusion, promoting the mental well-being, and to try to have a good food nutrition even at home. As a kidney patient organization, we have seen a change in our organization focus, because due to the concerns over the organization financial, and we are renegotiating the milestone for project, because our activities, especially face-to-face meeting or all the activities that we have planned in our budget has been changed with the pandemic. We are undertaking with the donor partners to try to maintain the same budget and to try to give the same support even at home. And what would we like as a kidney patient? Of course, we are claiming, we are trying to give the same social protection to the kidney patients, because we have seen that in the intensive care units, maybe we can be discriminated by age or disability or chronicity. So we would like to consider all the kidney patients that are risk group and vulnerable, because every person has the same social value. So we are trying to rating this medical inclusion, not discriminated by chronicity or something related with the pandemic. We have seen that the hospital medicines prescription maybe could be done at the community pharmacy or maybe with home delivery, because we have to reconsider that we used to go reasonable to the hospital or to the pharmacy, and of course we would like to have a guarantee of the supply with the security and safety of the materials, especially at home. Regarding the automatic prescriptions or renovations, yeah, we in the primary care we have seen we can do it. We can do it very well, because every prescriptions has been renovated by phone. So maybe the same we get used to go to the primary care or to the general practitioner too much times. So maybe it's a good idea to have automatic prescriptions and renovations even by phone. Regarding the telemedicine for consultation and postponements, we are claiming for the better data collection, and especially with the telematic assistance and the virtual support. But we have to be, well, we are considered that people with disabilities and elderly people maybe is not able to connect to the telemedicine and video conference, and we have to consider and to take in account that the phone is truly important today, and we have to balance to use the digital technologies with the old technologies that it is still important for especially for elderly people and people with disabilities. And regarding this best practice, we are claiming, of course, for the clear protocols to prevent and manage COVID-19 in dialysis units and home therapies, always promoting the home therapies and trying to raise awareness about family and caregivers, because family and caregivers, as you know very well, are a therapeutic element itself. So we can add, we can help a lot, and not only promoting the education to the patient, but also with the family and caregivers. And I'm always saying that the key of the empowerment of people is education. It's not only information. So we are trying to educate patients, caregivers, family, and or close relatives in this situation. And of course, digital data registry in real time. We are almost blind about the real data about how many patients are in each situation. So we are claiming for a real registry and digital data in online in real time, to know the real picture and to know what is going on in Europe about the chronicity and kidney patients. And at least, but not last, the best practice guidance in COVID-19. Everything who has worked for kidney patient is important to share with all the countries, and best coordination between countries and institutions, governments, and we are claiming for this kind of things, that everything should be better if we can coordinate it better between countries and between institutions and between patient organizations and between all the stakeholders related in the kidney community. And finally, to take kidney home messages, because we are in the arena, everybody of us, we are fighting and struggling every day with the COVID-19 and with the dialysis unit and the risk and avoiding a lot of things. We have seen a real disruption in our care quality and also in the quality of life, of course, by the pandemic. And we are trying to promote this telemedicine and this pharmacy pickup, not only at hospital, but also at home and in the community pharmacy. We are claiming for the better data collection and registry in real time. we are promoting the secure access to the kidney replacement therapy, even in the dialysis unit, with protocols and managing the best practice and trying to do the excellence. Of course, we have seen that the home therapies are the best therapies ever, the safest to remain stay safe at home. We are claiming that the people with kidney health conditions are a high risk group and considered like that, not only for the treatments, but also for the vaccines. And of course, the last claim for our group is to try to have a priority access to the vaccine when we're able next year, hopefully March, or hopefully before the summer, we will have a vaccine. And besides the professionals and all the people, elderly people, kidney patients should be considered as a priority group to have access to the vaccine. And this is more or less what I would like to share with you. And many thanks for your attention. My pleasure to have a questions or to have a discussion about that. Thank you very much.
Well, yes. Any questions for Daniel?
Yeah, I'm going to leave to share the screen, but maybe like that. No.
I think Spiros, maybe that you have a question.
Yes, I would like to congratulate you, Daniel, for the excellent presentation. It is very interesting to learn from you. I would like to ask how many percentage of people who do dialysis on a center can go back to doing dialysis at home, if it is possible?
Well, this is not very easy question, because as you know, a major part of people in dialysis unit are elderly people, but I think we should promote before the entrance of dialysis, before the need of dialysis, to promote all the home therapies, to try to have in mind that this is not an option for everybody, but maybe we have a low number of patients at home due to some factors, because maybe the professionals are disqualifying patients before entry to the dialysis unit, and maybe they are thinking that they are not able to manage it at home. But maybe we should promote and increase the number of people that are doing dialysis at home. I don't know how to get the share to screen. Come to
2 seconds. I can do it for you.
You can do it. Okay, great.
If not, I make myself present that.
Okay, great. Thank you.
Another question, Daniel. As you say, home dialysis is the safest option, but surgery for vascular access or peritoneal catheter is delayed. Different reasons. Or even education to take the treatment at home.
Yeah, training.
This means this means that this safe option cannot be increased.
Yeah, during the pandemic, of course, the training and the surgery for the vascular access, and including the catheter surgery, has been postponed or delayed because, as you know, the surgery rooms are not available for doing so. We have seen a delay, and everybody has to wait to go at home, because this reason. So yeah, this is not easy to manage, but we are claiming for that, because if we are promoting that people should stay at home, the only option is to have a home therapy.
Any other questions? Well, we can also move on to the next presentation, and that will allow, I hope you'll stay with us, Daniel. Yes, great.
Yes, of course, of course. Please go ahead. Thank you very much.
So if you come up with a sort of a question that you were too shy to ask just now, don't worry. You can still post the question. Yeah. Yes, Spiros?
I would like to ask Daniel the next events of the European Alliance. What your plans for your future events, awareness events?
Yes, Daniel, you're muted right now, but yes, he's working on it.
Yeah, sorry. Yeah, we have the president of the European Kidney Health Alliance. So Raymond, please, Ray, could you please answer the question? Because wait, I can't share, but I think you are the president of the EKHA, so I think you are the right person to do it. So.
Yeah, but I must say there are a number of activities going on. We have one initiative running on home dialysis, which had its webinar already, but now we are producing a paper, an open letter actually, based on this. Then we have also two activities pending on transplantation, promotion of transplantation, one in the context of the Portuguese organ transplantation society, and one broader. And then for next year we have a forum pending, which will be on patient access and reimbursement of treatment. And then also from next year on, we want to promote the view of kidney disease as a problem, which is still very much neglected by politicians. And we want to install, in parallel with what is happening in the United States, a decade of the kidney, which would run from 2021 to 2030. And where we would like to get the same attention for kidney disease as has now been given correctly for cancer. But I think that the kidney issue is as important, but usually forgotten. That's it.
Yes, and I would like to add, as a EKPF, we have
maybe.
Sorry. The next week we have a capacity building training program for the EKPF members to improve the skills in advocacy, because we are claiming that to address all in the EU agenda of the policymakers that the kidney disease as a kidney patients, we have to improve our skills to speak with the MEPs on the policymakers. So of course, all of you are invited to join our capacity building training program.
Thank you very much. And perhaps collectively, Spiros, we can also do our best via our LinkedIn and Twitter profile to share dates about those events for well, everyone to join. But right now we are moving on to the next presentation.
Michalis, are you there?
Yes, Spiros. Good morning, everyone.
Probably we can say a few words about the ECARIS project.
I can.
ECARIS is a project about kidney patients at stage from 1 to 4, dialysis patients, peritoneal, transplanting, and of course their caregivers. Our first goal is to educate caregivers about the problems and the needs they face during their daily routine. We hope during the intellectual output number 2 to gather all these necessary elements to give them the necessary information about handling a chronic disease like CKD. I did a question in the chat room, but probably Daniel didn't show it. Lars, can I ask something? Daniel, could you please tell me if there is a responsible organization in Spain for telemedicine and in-home assistance, or every hospital is responsible for its patients?
Yeah, of course, but not in all hospitals we have developed in time the telemedicine. You know, this is not easy to do it in real. I think, yeah, we can discuss after, because Raymond, do you see the presentation?
Yeah. No, I'm ready. Sorry for the problem with the slides. And thank you for helping me out. So good morning, everybody. Thank you very much for inviting me to present to you the problem of kidney disease and COVID-19 with a number of things that have been already discussed by Danielle excellently. So you will hear a few things that come back again. And with the first slide, I just want to explain who we are. On the next one, Danny. The EKHA, I'm representing the European Kidney Health Alliance. That's an NGO that's based in Brussels, and it's advocating for the needs of kidney patients and of the nephrological community at the level of the European Union, and from there, top to bottom to the national level. And we are not only, as you can see down below on the left side, representing the Finnish physicians, which is ERA EDTA, but also the nurses. We are very happy to have at last a very active patient group with Dani and the European Kidney Patient Federation, and we have also the foundations on board. So as a matter of fact, we are representing the major European societies representing patients, etc. And then on the right side, you also see that we have a number of national societies who are supporting our actions, and every other society that would become or is willing to become affiliate member is of course welcome. The next. Before going to COVID, I just briefly want to re-emphasize the problem of chronic kidney disease and its burden, although you are very well aware of it, I suppose. So next slide, if you take 10 people, then on the next slide, you will see that at least 1 in 10 of them is suffering from chronic kidney disease. According to some statistics in Europe, it's even 1 in 9. And the next slide, as Dani already stressed, that is representing more than 75 million of Europeans who are suffering from chronic kidney disease. The next, but what is perhaps even more important is that 1 in 3 is at risk of chronic kidney disease. And as a matter of fact, we do not know who will of these 3 evolve into the direction of chronic kidney disease and who not. And quite a number of people who do not evolve to chronic kidney disease just do not do that because they are dying. So we suspect that with better treatment of other chronic diseases which are at the basis of kidney disease, the number reaching the stage of chronic kidney disease and finally also of renal replacement therapy will even become larger. Next slide. Now, the other problem is that this is a devastating disease. On this slide, you see the 5-year survival of patients with different types of treatment of the end stage of kidney disease, which is, of course, the most severe state. And I ask you to concentrate on the 2 bars that are surrounded by a red rectangle. On the left side, you see the 5-year survival of hemodialysis patients, which is, as Danny stressed out, is still the group with the largest group of end-stage kidney disease treatment. And then somewhere in the middle, you see in the blue bar, you see the aggregated mortality data for all cancers together. In between, there is also another red bar that's for the PD patients. And then to the right, you see 2 other red bars. These are for transplant patients. So it is clear that the 5-year survival of hemodialysis patients is worse than for all cancers together, and that, as a matter of fact, there are only 2 cancers with a higher mortality. These are respiratory cancers and neurologic cancers. All the rest is better. PD is still worse than all cancers, and for transplantation, the figures are a little bit better, but it's really not impressive, and is still preceding a number of cancers. And the next slide. And on top of that, it is also a very expensive disease for society, and the yearly cost of CKD, and CKD, that's all kidney disease together without acute kidney injury, which we then still forget. So the yearly cost of CKD and cancer is at least the same as is illustrated on the next slide, where you will see on the right side the healthcare cost of chronic kidney disease, and on the left side that of cancer. And chronic kidney disease is split into several parts. The blue one is for dialysis, the red one for transplantation, and not on kidney replacement therapy is purple. So first of all, it is clear that the cost for chronic kidney disease at large is at least as important as for cancer. Second, it is also clear that the largest cost is coming from chronic kidney disease, not on kidney replacement therapy, not because the cost is that high per patient, because that's much more important for dialysis, but just simply because there are many more patients. But of course, this comparison with cancer does not mean that we do suggest that cancer would receive less attention. I think that this disorder receives rightfully the attention it gets, but what we want to stress is that attention and investment for chronic kidney disease would be at least as important. The next slide. And knowing that, we now moving to COVID-19 and kidney disease, being aware of the fact that, of course, this COVID-19 was affecting this group that was already quite heavily struck by the disease as such. Next slide. And then, unfortunately and quite confusingly, the first reports we got from China and Wuhan were suggesting that there were not that many kidney patients among people hospitalized. As you can see in this slide, it's less than 1% for chronic kidney disease and kidney replacement therapy, which is a bit surprising because we know from these data that risk factors for chronic kidney disease like diabetes, that those groups were quite heavily represented. Next slide. But we had to wait for United States data, and that is already beginning of April, before seeing appear data on chronic kidney disease. And I want to stress that these are American data because in Europe, unfortunately, the Centers for Disease Control, which are the equivalent of the American CDC, that they do not register for chronic diseases, only for infectious. So we knew quite well what was happening with COVID-19, but not in how far it was affecting chronic diseases. So for this, we had to rely on the United States. And here you see already the trend that will become more and more clear later on. If you look at the left side, that's the percentage of people being hospitalized. And on the right side, the percentage of people being admitted to the intensive care unit, which are the most severely affected patients. In blue, chronic kidney disease, in red, cardiovascular disease, in green, diabetes mellitus, and in purple, all other chronic diseases together. So here, for the first time, we saw that chronic kidney disease patients were heavily represented in the most severely affected patients. But of course, this is the United States, so there is more diabetes mellitus, there is more obesity. So this could be specific for the United States. And the question still remained, what is happening in Europe? The next slide. And those data on a large group of patients we got at the beginning of the summer in this eye-opening paper in Nature, where you see the relative risk to die for several different conditions. So I briefly explain the figure. The vertical red line that you see, that's the standard population. The mortality of that population is set at 100%. And then all other dots are the relative change in mortality risk for several different types of populations. They are obesity, diabetes, chronic kidney disease, everything is in there. So if the dot is moving to the right side, then the mortality is worsening, worse than in the general population. And the data on chronic kidney disease are surrounded by the red rectangle. And the dot below is for a GFR smaller than 30 mils per minute. So those are not the patients on dialysis, but quite severe kidney disease. But you should know that the mortality of dialysis, which is mentioned in the paper but not in this figure, is almost as high. And it is set at something like 3.5. So that means that the risk to die is increased by 250%. Next slide. Now, if you now look at the vertical blue line, which indicates where we stand with chronic kidney disease, then you will see that there is only, apart from age, which is up at the upper part of the slide, that there is only one condition that is doing worse than chronic kidney disease. That's the dot that is 4 or 5 rows above it, and that is people with hematologic cancer during the first year. So that's a relatively small population compared to the population with chronic kidney disease. So everything is worse, and kidney patients are equivalent to the age stratum of 60 to 69 that you see above. So that's already elderly patients with a pretty severe condition. And then there is only one group that is even doing worse, and that is the group below in the next slide, and that group is the transplant patients. So that's also concerning us with kidney patients. The picture is a little bit distorted in a way that the large mortality seems to be there for lung patients, but for kidney patients it's certainly not much better. And then you see that for this we're projecting right in between, up to 70 years and between 70 and 80 years old. So that's quite a severe problem. The next slide. But unknown to many, unfortunately. And these data are then confirmed in several studies showing the mortality in kidney replacement therapy. These are data from the ERA EDTA registry with above a 20% mortality of transplant patients, 21% of dialysis patients, and if corrected for comorbidities, then the risk of transplant patients is even slightly higher than in dialysis. And also the 20% is relative because, for instance, in my own region in Flanders, where we were quite severely hit by COVID, mortality during the first wave was 30%. The next slide. And now the other problem that we saw that has been alluded to already is that the transplantation rate was dropping dramatically. On the left side, you see data for the first wave for France. If you look at kidney, then it drops virtually to 0. That's the blue line, the blue line among those lines. On the right side, you see the data for Spain. And those are extended a little bit longer. That's very interesting to see. So you see the dip. Dip doesn't go to 0, but still it's quite severe. Then that's in the months of April. Then it goes up again. And in June, they have recovered, but not entirely recovered. And then you see already in September, that's the point most to the right, that is dropping again. And that is conform with the beginning of the second wave in Spain. So it will be interesting to see what happens later on. And we must stress that in Spain, the transplant organization quite efficiently dealt with the problem compared to other countries. For instance, in Belgium, I know we were at zero, virtually zero. We barely recovered during summer, and we are back at zero during the second wave. So that's a huge problem. Next slide, taking into account that according to our data, and now you have to focus on the yellow line, that's the percentage of people on the waiting list for transplantation for kidney who are dying. It's not for kidney, it's for transplantation at large. And that means that 3 to 4% of the waitlisted people are dying. And that just simply means that with this COVID situation, the number for 2020 of people dying on the waiting list will be much more important than in previous years. So that's a serious problem. Again, unknown to most of the people outside of the nephrology world. Next slide. Now, the other point that is interesting is the comparison among different kidney replacement therapy options to develop the disease. So this is not about mortality, this is about the risk to develop the disease. And these are Italian data. First of all, you see a geographic distribution where the hue of the color indicates the severity regions were struck. So there is quite a striking similarity between the three modalities that are displayed here: hemodialysis, peritoneal dialysis, and transplantation. Next slide. But more interesting maybe is the risk to develop the disease, which, as you can see, for hemodialysis is 3.50. And in peritoneal dialysis, something like 1.3, 1.4. So that means that for hemodialysis, and that's then in center hemodialysis, the risk to develop the disease is about 2.5 times higher than for peritoneal dialysis. The next slide. And if we then move to transplant, then you see a figure below 1. So here, the risk is 4 times higher for in-center hemodialysis and transplantation. That's not a surprise because the PD patients and the transplant patients are treated at home. And in-center hemodialysis is a closed community, a bit like retirement homes, like nursing homes. So it is clear that the risk to develop the disease is, of course, much larger in this group. Which also means that one of the things we want to focus on in future is again to promote home dialysis treatment, home hemodialysis and peritoneal dialysis and transplantation. The next slide. And of course, during the pandemic, telemedicine was of very much help, but we should realize that not everybody has a computer, that not everybody is computer literate. And that those that are eliminated in this way are also the ones that are most vulnerable to COVID, that these are minorities, refugees, ethnically different people, elderly people. So this must go together with a policy action towards computer literacy in as much as this is possible, to our opinion at least. Next slide. Now there is this other kidney problem that is at least as severe and which is perhaps even more forgotten than chronic kidney disease. There's acute kidney injury. That's the thing that happens in the most severely affected patients. And in this series, you see that almost 60% of hospitalized patients were developing acute kidney injury. And of those, 35% were dying. So if you look below at the bars, and the dark bars are showing the mortality, the left one is no acute kidney injury, and then to the right you have more and more severe stages of acute kidney injury. So it is clear that as acute kidney injury becomes more and more severe, mortality is also becoming higher. And in the most severe group, which is also the group that needs dialysis, it's almost 50%. And of course, the other important point to raise here is that with acute kidney injury, there is in the non-COVID population about a 30% risk to develop chronic kidney disease. So we can expect that also many of these people will show up now in the group of chronic kidney disease patients. The next. And in the margin of all this, there were also a number of practical problems. In the New York area, there was a shortage of dialysis material, which was mostly due to a lack of organization and also to a lack of insight in what kidney disease is and kidney disease treatment. So there was a tendency to go for continuous kidney replacement therapy, but with kidney replacement therapy, you can treat only one patient per position. And on top of that, there is a lot of clotting in the dialysis system in that disease. And of course, COVID was a clotting disorder. So that made things very much worse. So probably if there would have been some better communication among specialties and people would have listened earlier to nephrologists, and maybe also due to lack of awareness of hospital administration at large, and maybe also even of nephrologists themselves, then things would have gone better. The next slide. And there was this problem of shortage of protective material, which of course put also the personnel at great risk. And then still on the next slides, a few of other specific points. The insertion of PD catheters was postponed as a non-emergency, at least in some country. Personnel, as already stated, was in close contact with patients, and that increased their infection risk. And if they were more infected, then there were more dropouts. The next, and those who were left were overworked and they got burnout. And if there was burnout, there was more of dropouts. So that was also a serious problem. The next slide. There was this huge thing that is not directly related to COVID, but that we know is happening all the time. It's the exclusion of kidney patients from therapeutic studies, which also involves treatment of COVID, like with remdesivir, so that the nephrologists are left more or less in the dark on how to treat this. And it is very well possible that remdesivir is acting quite differently in the kidney population than elsewhere. And this problem also will be the same for vaccination, where we know that kidney patients react not so very well to vaccination. But as far as I'm aware, there is only the Pfizer vaccine where kidney patients will be excluded. All other vaccination studies just simply exclude kidney patients. And finally, the next, there was also exclusion of a number of CKD patients from critical care, not because they were in a bad condition, but just simply because they had chronic kidney disease. Again, a consequence of a lack of awareness and of thinking that this population is a population with chances to survive COVID, to not to the same extent, but almost same extent. And still, the majority of CKD patients with COVID survived. The next slide brings us then to the conclusions. The population with chronic kidney disease is one of the most heavily affected by COVID-19, if not the most. The next, this dramatic problem went largely unnoticed to the general population, including administrators and policymakers. Next slide. This problem can only be solved by prevention and a shift to home therapies, including transplantation, and it is the responsibility of the kidney community to create awareness about this problem. So I'm very happy to learn that our patients are going to this course of advocacy next week, because that will be very useful. I thank you for your attention.
Professor Vanholder, in your presentation, you showed that COVID-19 infection caused the acute kidney failure in many patients, but have chronic kidney disease increased in this month during the pandemic?
Of course, I don't know. There are no data for the time being, and I'm afraid that again the European community, nephrology community, is not paying enough attention to acute kidney injury. So we are also, for the time being, installing a network of acute kidney injury interested units. But it's coming for COVID, it's coming a little bit late. But we know that the Americans are looking at it. So I would not be able to answer, but I just extrapolate from what we know from before COVID-19. Some of these people just do not get off dialysis, and some of them will develop chronic kidney disease, will remain with a certain degree of chronic kidney disease and worsen later on. And some may even become entirely normal and then still have a worsening kidney disease. The other side of the problem is, of course, that also a number of chronic kidney disease patients had acute kidney injury on top, which is, of course, also a very negative factor, I suppose. Does that answer your question?
I think.
Mr. Vanholder, good morning. I'm Mike Sakadakis from Greece. I have a question for you. In your opinion, do you think that the healthcare systems of European countries are well prepared to address the increase of CKD patients due to the COVID infection? From papers and surveys, I read that they expect about a 50% increase of AKI patients due to the COVID infection.
Yeah, that's right. As a matter of fact, I know from our own hospital that it was a dual problem. So there was the AKI with COVID, and there was also more AKI of non-COVID patients just because they came too late. And I think, I don't know, I'm not aware how it went in other countries. I think in Belgium, the system, but I must admit that our system is quite well developed, was just at the limit of being able to deal with it during the second wave. The first wave was better. But the problem in Belgium was just simply that we had, like usually, no government, and that's a very good situation. That is, things go better without a government. But in this case, the replacement government had made a number of wrong decisions at the end of its term, and actually relaxed too much. And so the big problem in Belgium has been a problem of discipline of the population, which makes that our second wave was worse than the first one. On the other hand, I hear that the group of hospitalized patients that moves into intensive care is proportionally smaller, but that the mortality on intensive care is the same as previously. I also hear, but it's more difficult to judge from a distance, that in many other countries, the healthcare system was much more stressed. As far as I can understand, that was the case already during the first wave in Spain, and it was also so in northern Italy, although their healthcare system is also running pretty well. I hear that it's now the same in southern Italy, where the healthcare system is much less well developed. So I must say, yeah, the systems are probably at the limit of their possibility, but of course it's also something quite exceptional that happens. It's like an earthquake, more or less. In earthquakes, I've seen happening the same thing, but that is then limited to a certain region, and you can move your patients to other regions. But here you can't. Everybody faces the same problem.
Thank you very much, Raymond Vanholder.
Well, some great presentations, and thank you very much both to Danielle and Raymond for joining us today and enlightening us so. I will encourage you all to go into those two particular websites, check out the new and upcoming events, and share some of the tools that you find there as well. As Daniel and Raymond rightly pointed out, this is an area that needs more attention. Well, one thing that you can do is share some of those across your current, well, social media, if anything else. And you'll be glad to know that this week we actually have a lot of other good organizations out there that might be willing to share some of them across Europe. We have a long way ahead of us, all of us, especially in getting just out of 2020. But luckily towards 2030, as Raymond says, there's ample time to well, hopefully arrive at a better destination than the train station we're leaving. Yeah. Thank you very much all for joining us today. We'll look forward to a session later today, but also a session tomorrow about, of course, focus groups and how to engage professionals across borders. Once again, signing off from the Danish Committee for Health Education on behalf of the ECARIS project, it was a pleasure.